centuries ago, in 1783, Alexander Monroe applied some physics principles to intracranial contents and hypothesized for the first time that the blood circulating through the skull was of constant volume at all times. Experiments conducted in 1824 by George Kelly, an Edinburgh surgeon and Monroe's student, validated this hypothesis. This became known as the Monroe-Kelly doctrine, and it is critical in understanding intracranial pressure. The pressure inside the skull, as measured by cerebrospinal fluid pressure, is known as intracranial pressure. It is a pulsatile signal that is triggered by the cardiac cycle and is often marked by three distinct peaks. ICP pulses, or wave pressures, have gotten less attention and study than mean ICP pressure. The mean intracerebral pressure should be kept within a restricted range of 7 to 15 millimeters of mercury for adults, 3 to 6 millimeters of mercury for children, and 1.5 to 6 millimeters of mercury for term newborns. For traumatic brain injury and acute brain damage, published guidelines indicate that an intracranial pressure of 20 to 25 millimeters of mercury in the intensive care unit is advised. The intracranial space has three major components: cerebrospinal fluid, blood supply, and parenchymal tissue. Maintaining intracerebral pressure is critical. According to the Monroe-Kelly hypothesis, every change in volume to any component will result in a corresponding shift in intracranial pressure. An exponential function, the intracranial elastance curve, describes the connection between ICP and volume within physiologically relevant limits. An increased ICP generally suggests that the buffering capacity has been depleted to some extent, whereas a normal ICP does not always imply that buffering has not already been damaged. ICP is a critical condition that affects the volume of the brain, with cerebral blood flow and the balance of CSF generation and absorption being the two primary components. Increased ICP and intracranial hypertension result when the volume of one component rises without a corresponding reduction in another. Compensatory mechanisms exist to allow moderate volume increases. Still, when they are exhausted, ICP rapidly rises until it approaches critical closure pressure, CRCP. At this point, cerebral arterioles collapse and blood flow stops. Input pressure, mean arterial pressure, intracerebral pressure, and cerebrovascular resistance all influence cerebral blood flow. In circumstances of elevated ICP, a cascade of mechanisms is normally used to maintain cerebral blood flow. Although these mechanisms can occasionally result in intracranial pressure and cerebral ischemia, because blood flow remains relatively constant over a range of ICP due to autoregulation, ICP monitoring is critical in neurointensive care settings. Various circumstances and physiologic factors can cause altered ICP, complicating non-invasive ICP assessment methods. A universal approach to ICP measurement should ideally account for natural hemodynamic variability between patients.